like to welcome you all in this webinar, and gratitude, thanks to the international department for the invitation. Now I'm sharing my presentation. Okay, so today's lecture is about breast cancer symptoms, diagnosis, and modern treatment options. And we know that breast cancer is a very frequent tumor. According to the global CAN statistics, right until 2020, it was second after lung cancer. But something interesting happened last year. And now we're starting to see that the incidence of breast cancer has risen to the first rank with 11.7% of new diagnoses globally now is breast cancer, and it ranks first, followed by lung cancer. According to the death data, we have seen a decrease in mortality rates. We know that lung cancer is still ranking first in mortality due to cancer. Breast cancer deaths account for 6.9% globally. So why did it happen? We know that there are 4.4 million female cancers, and about 25% of all these cancers, I mean 9.2 million cancer incidents, but about a quarter of these is breast cancer, and about all deaths, female deaths, 15% of those accounts for breast cancer. So now that the incidence has risen, one of the main reasons for that is industrialization. That's living in the city life is not good for breast cancer because we do not exercise, we just sit all day long, and of course diet. A diet rich in fats also accounts for the high incidence of breast cancer. And now later on, we're going to be touching on these subjects. So, however, although the incidence is rising, cancer mortality is dropping, not only for breast cancer, but also lung cancer, prostate cancer, colon cancer, and melanoma deaths are decreasing by 30%. So about a third of cancer deaths have been prevented. Although uterus, pancreas, and biliary cancer mortality is increasing, all these are dropping thanks to earlier diagnosis with awareness programs and also advances in treatment. So when we look at breast cancer, because today's topic is breast cancer, we can see that, as I've told you, the incidence is rising from 2000s, but the mortality death rates is decreasing overall by about 36%. And about there is this advances in treatment that has resulted in a decrease in this mortality. So what is breast cancer? Breast cancer is a cancer of the breast, but about 95% of breast cancers arise from the lactoferrin ducts and the epithelial lining covering the ducts. That's where milk is passing through when we're in lactation. What about risk factors? We have uncontrollable risk factors and those that we can control that increase the risk of breast cancer. So we know that one of the major uncontrollable risk factors is age. Breast cancer is a cancer of the elderly. However, this was so because it's starting to change, because in countries like ours and also in the Middle East, we are seeing much increased rate of breast cancer in earlier ages, less than 40. About 25% of breast cancers in Turkey occur in patients who are aged less than 40. Also gender, it's a disease of the females. However, we see male cancers as well. And also there are genetic factors. We know that about 10% of breast cancers arise from a risk that runs in the family. These are called hereditary tumors. And there are also other diseases associated with all these genetic factors. Early menarche, which is before 12 years of age, and an older menopause age, that is after 55, and also a family history of breast cancer, And exposure to radiation of the chest area due to a childhood cancer increases the risk of breast cancer. The risk factors that we can control are that's giving birth at an older age or having no children at all, not breastfeeding, using hormone replacement therapy after menopause, eating lots of processed and fatty food, hormonal birth control methods, lack of exercise, and obesity are very important factors that increase the risk of breast cancer. So these are very important. And these are the main reasons why we are seeing an increased rate, an increased incidence of breast cancer these days. So how do we prevent it? Well, we need to exercise, we need to maintain a healthy weight, and we need to limit the alcohol intake to maintain a good lifestyle and also decrease our risk of breast cancer. So about diets, there's this cartoon that I like because not all diets work for everyone. And I can see a lot of faces now. I can imagine a lot of faces now saying that, okay, I have friends who have not eaten, who are very thin, who have given birth and breastfeeding, but have breast cancer. Well, it depends from person to person because there are also some genetic and environmental factors that we can't control that result in breast cancer, although we have no other risk factors. So this depends on personal level as well. So what are the symptoms? Well, first of all, what needs to alarm you? If you have a nipple discharge, especially if it's bloody, it may be important. An areolar ulceration, discoloration, or flaky skin may be important. A lump in the breast is, of course, very important. Most of the time, the lump is not painful, but about 5 to 10% of the cases, it may be painful. So there is no, rule of the thumb there. A thickening of the skin, nipple pulling are important symptoms that may be associated with breast cancer. We, of course, don't want to see these images anymore, and we normally don't. But an ulceration of the skin, a lump in the axillary area, some painful and erythematous nodules, subcutaneous nodules around the breast area is very important. And people who are seeing this should see a doctor immediately. Of course, as I told you, we don't want to see those images anymore because we know that breast cancer is a curable disease when detected at earlier stages. So this is something that we should not forget. How do we diagnose breast cancer? Well, of course, mammograms. As you know, yearly mammograms are indicated for all women after 40 years of age and should be done annually in order to determine whether there is a cancerous tissue in the breast so that it can be detected at an early stage. Here we can see this breast tumor in the mammogram. And we know that breast cancers, when found in the breast tissue, can involve or can spread to lymphatic tissues that is surrounding the breast tissue. All areas here that you can see is the breast tissue. So this should be examined. And of course, lymph nodes should be examined with an ultrasound as well after physical examination. So what are the stages of breast cancer and what is the risk of metastases with respect to stage? If there is only a lump in the breast and no lymph node involvement, it's called stage 1. So this is a disease that is limited in the breast tissue. A stage 1 disease has a very low propensity, a risk of metastases, which ranges between 2 to 20% with respect to the molecular biology of the tumor. Stage 2 tumor is a tumor when the tumor is in the breast and also the axillary lymph node is involved. So there is a axillary lymph node metastases. And here the risk of metastatic involvement is within 15 to 30%, with surgery only, of course. And stage 3 disease is a tumor that is spread to not only the axillary lymph nodes, but also other lymph nodes that are surrounding the breast tissue, the mammaria interna and the supraclavicular lymph nodes. And this is stage 3. And the risk of metastases here is very high, ranging between 30 to 70%. So how do we screen patients and how do we get an early diagnosis? First of all, a self-examination is very important. In perimenopausal patients, this should be done after the menses is completed, within like 2 to 4 days after menstrual periods. One should examine the breast. And also if there is a risk, a family risk, you should also see a physician who should clinically examine you and see whether there's any formation in the breast. And of course, imaging. As I've told you, the standard of screening is annual mammographies obtained after 40 years of age. And this should be coupled by an ultrasound and also an MRI if required. So a mammography is this machine that you can see. It squeezes the breast so as to take X-rays of the breast. And we see the images here, the right and the left. And these are normal images. If there is a lump, then it should appear like this opaque image in the mammography, like this. So this is a breast tumor. It looks very dense, and there are also some spinous formations here. The boundaries are irregular, so this is a breast cancer. So when we see an image that is suspicious for cancer, the diagnosis is done through a biopsy. This biopsy is usually taken through an ultrasound, under an ultrasound imaging, through a needle that is put in the lump area and then obtained. And this biopsy is evaluated by the pathologist to see diagnosis of breast cancer. The workup should include a staging prior to surgery. Staging means whether the tumor is spread to other sites of the body and the lymph nodes, of course. So usually it requires a PET-CT or a CT and an MRI. And after we have data from these images, we have to make a treatment decision. The treatment in early stage lung cancer is surgery, chemotherapy, endocrine therapy, or targeted therapy, and of course, radiation therapy that I've omitted here, not on purpose though. But the sequencing of these types of treatments may change according to the biology of the tumor and also the stage. So chemotherapy is drugs that are given intravenously. And the aim of this treatment is to eradicate circulating cancer cells. And also, sometimes we give chemotherapy before surgery to shrink tumors, to facilitate a conserving surgery, like less axillary dissection. And it depends on the biology of the tumor. So chemotherapy is a very important type of treatment in early stage of disease when the tumor is still curable. As I've told you, there is an increased risk of metastatic involvement. As stages go up from stage 1 to stage 3, the risk of metastatic dissemination increases from like 2 to 5% to 30 to 70%. And with chemotherapy, there's a 25 to 50% relative benefit. That means it decreases the risk by half, almost. In those tumors which are either too large to get operated, ulcerated tumors, a lot, extensive breast or axillary involvement, or in those tumors which are biologically responsive to chemotherapy, we sometimes give the chemotherapy before surgery, and this is called neoadjuvant chemotherapy. Especially in tumors like triple negative breast cancer, which do not express hormone receptors. By hormone receptors, we mean estrogen and progesterone receptors. So, and this is a triple negative breast cancer patient, age 52. As you can see, there's an extensive involvement of the lower half of the breast with a lump that you can see that has invaded the skin. We administer chemotherapy for 6 months, and the tumor has, decreased by about 95% or so. There's just this residual skin discoloration left. And when the patient has been operated on, we can see that all tumor cells have died. And this is a pathologic complete response. This is very important because when we get a pathologic complete response, we also tend to have a higher survival benefit in those patients. This is a patient with a HER2 positive disease, a locally advanced breast cancer. As you can see, the whole tumor, the tumor has invaded the whole breast cavity. The skin is involved, lymph nodes are involved, as you can see. This patient is a 39 years old patient, premenopausal patient, received chemotherapy plus a targeted agent that targets HER2, and the tumor has shrunk by about 70% or so. Of course, when tumors come at a very advanced stages, the response of achieving the risk of not achieving a PCR decreases, as happens in this patient. So this is why detecting tumors at an early stage is very important. Therefore, at this time, and when we look at the timeline of between, the previous 2 decades or so, we use neoadjuvant chemotherapy more and more often. Before this era, we used to administer chemotherapy to locally advanced cancer patients. Now that we are giving neoadjuvant chemotherapy at earlier stages, as early as stage 1 patients, if they're HER2 positive or triple negative. So this is something that should be kept in mind. Before referring patients to surgery, we need a multidisciplinary evaluation to determine whether patients need chemotherapy and targeted therapy first. And we're going to be talking about immunotherapy as well. Endocrine therapy is very important for breast cancer patients because we know that 70% of breast cancer is estrogen dependent. Estrogen is the female hormone, as you know. And tumors have this estrogen receptor. Also, progesterone receptor means that the tumor is responsive to endocrine therapy. So we administer endocrine therapy most in all patients who have estrogen receptors and progesterone receptors expressed in their tumors. Here, the aim is to decrease the estradiol level and also suppress or modulate the estrogen effect on existing cancer cells to stop them from disseminating to other sites of the body. So when we look at the evolution of breast cancer treatment from the 20th century to the 21st century, we know that in the 20th century, we use clinical prognostic factors to determine the stage and also decide what kind of a treatment the patient needs. And this was all dependent on the T&M stage and one for all treatment. However, when we came to the 21st century, it is an era of molecular and genomic prognostic factors, and the tumor biology is the most important factor of all. So we use those factors to determine whether a patient needs chemotherapy first or whether she needs immunotherapy or targeted therapy. And this is called a personalized approach, which has opened up a new era in all oncology for most of the cancer patients. So what is personalized treatment? For a personalized treatment, first of all, we need something called a biomarker. And when we find this biomarker, we give the treatment according, in order to suppress this or target this biomarker. This is called targeted therapy. In order to evaluate what kind of a biomarker or a molecular alteration lies within the, the causative factors of the tumor, we need to detect the genomic analogy of the tumor. So we need to get a biopsy like this from this, the bright area seen in the PET scan here, and also perform an NGS or a next generation sequencing genomic test to identify what biomarkers have caused this tumor. And so a personalized treatment here, when we find this biomarker, it refers to the tailoring of medical treatment to the individual characteristics of each patient. So we see a patient, we know the clinical presentation, we should know the pathology from the biopsy and the pathologic evaluation, and we also need the genomic profile identified so as to deliver a personalized treatment to this patient. So this is what personalized treatment is. So when we see a breast cancer, of course, it's not one type of tumor tissue or one type of tumor cells present, but we have like 4 or 5 types of tumor cells, different genomic profiles within each tumor, not only in each patient, but also within the tumor itself. So it's a heterogeneous tissue. And some of these cells are prone to only surgery, don't need any treatment at all. Some need chemotherapy or endocrine therapy. Some need targeted agents. So when we encounter with a tumor, we have to know what kind of a tumor this is genomically and clinically to decide about what type of treatment to give. And as I told you, this is the personalized approach for each patient. So this is what we do here, and this is what should be done for each patient. So it's unique, each patient is unique in herself. So what is different in breast cancer treatment? So we have got a lot of excitement throughout the years for new technologies. New technologies have yielded us new drugs. We have a new generation of conjugated drugs for our patients. And this is a very new drug that we're using in triple negative breast cancer. We have an antibody that targets the cell and also a chemotherapy agent that is linked to this antibody, and it binds to the tumor cell, is taken in within the cell like this through binding. When it enters the cell, it undergoes a cleavage which releases the cytotoxic agent within the cavity, and then the tumor cell is killed. So this is a targeted chemotherapy. And this is what we are using now in HER2 positive and triple negative patients, and have resulted in very successful rates, especially in HER2 positive disease. This has been used in the neoadjuvant strategies as well as metastatic patients, and have resulted in a great improvement in outcomes. So what about immunotherapy? What do we have in breast cancer? We have just, starting with other cancer types like melanoma, like lung cancer, we have been using immunotherapy for like 5 to 6 years now. Recently, we are seeing some developments in breast cancer as well. So what is immunotherapy? First of all, lack of immune rejection is a very important, a fundamental hallmark of cancer. We know that tumors tend to grow using some molecular pathways, but the tumors also respond to their environment and cause immune cells to decrease and to get ineffective. So we have an immune surveillance in our body, which are flying all around the body, which to recognize the foreign cells. However, we know that tumor cells, like the stealth airplane here, can overcome this immune surveillance, just flow under the radar and escape, so as to form themselves some kind of area and grow, and then evolve to other areas of the body. So immunotherapy is actually, other than the tumor itself, involves modulation of the host environment. It refers to the modulation of the host immune system to fight the cancer. What are immunotherapy strategies? Some cancer vaccines, adoptive T-cell therapies, gene therapies, and also the new strategies to release the immune brakes, or the tumor's ability to suppress the immune system and to target this immune suppression, is a very important immunotherapy strategies. Now that we are using all these types of immunotherapies and other types of cancer, however, in breast cancer, we have started using this other immunotherapy strategy, which is called immune checkpoint blockade. And this is releasing the brakes in the immune system. When we, just as an analogy to a car, the antigen or the tumor itself is the, car's contact system. The gas pedal is just this B728 model here. When you can see it just it's a molecule that binds the immune cells and direct them to the tumor cell. There's also the tumor cells effect in preventing this. And immune checkpoint blockade is these monoclonal antibodies or just targeted drugs that target those receptors that cause this immune suppression. And we have some drugs called CTLA-4 inhibitors or PD-1 inhibitors that release the brakes on this system. In breast cancer, it is pembrolizumab that we're using in triple-negative breast cancer in conjunction with chemotherapy that results in an improvement in progression-free survival and now overall survival in the frontline metastatic setting. So when we have triple-negative breast cancers who have presented with metastatic disease, we need to check to see whether these patients will respond to immunotherapy. And also, since this is a very effective treatment system, we have also started using this combination in neoadjuvant treatment so as to improve the PCRs and also improve outcomes. And this is, again, very important. When we see an early stage patient with triple-negative breast cancer, also don't forget to refer them to the medical oncology department for addition of immunotherapy in their chemotherapy. So when we look at the treatment decision-making in breast cancer, we have to consider prior therapies, biologic factors, stage, and also personal factors like comorbidities, performance status, expectations in order to make the best approach for these patients. And this is called a personalized approach. Breast cancer management depends on a 4-tier system, which is very important, all of them, and form this all relevant parts of the puzzle in order to complete it. And early diagnosis is mandatory. Multidisciplinary care is very important to determine which treatment is good for the patient per se. To determine a personalized treatment approach is very important. That improves the outcomes. And also continuing research is very relevant in order to continue to know the tumor and to make the best treatment. So I'd like to thank you all for listening to me, and happy to take any questions that you may have.
Professor, thank you for this fascinating presentation.
Thank you.
There is a question I want to ask you. Do you make genetic testing for every breast cancer patient?
Yeah, especially if those in patients with triple-negative breast cancers who are 60 years old or younger, we need to have a hereditary test that is obtained from the blood. And also in those patients who are premenopausal and have some factors that not only triple negatives, but also if they have cancers running in the family, then we need to have them tested for any hereditary mutations that they might have. Other than that, hereditary means that we have some genes that we acquire from our patients and we just deliver them to our kids. Other than that, the tumors itself may harbor some genomic alterations, and these are not hereditary. These are called somatic mutations. And sometimes we do this testing in the tumor biopsies that we obtain from our patients to determine whether they will be responsive to some targeted therapies, immunotherapies, etc. So these two types of tests are obtained to most of the patients that we see.
Thank you, Professor. Dear participants, if you have any question, you can write on Q&A box.
I guess there's one.
Yes.
Oh yeah, that was your question. Okay, genetic testing for.
Professor, I guess everything's are clear. Thank you this again fascinating presentation. I hope we can meet again for different webinars. Thank you so much.
Hope so. Thank you very much. Thanks for the invitation. Bye-bye. Have a nice day.
Bye-bye. Dear participants, Dr. Davor is Acibadem, is our representative in Croatia. He will give a closing speech. Please, Dr. Davor, speech is yours.
Thank you very much. I hope you can hear me. I wish to thank Professor Eralp actually at the beginning for this really informative lecture. I'm sorry I couldn't be with you from the very start because I had a meeting here at our hospital, but it was really very clear, and I think that even someone who is not in medicine could understand and get some insights into this disease, breast cancer. Immunotherapy is definitely a treatment that has become a new standard of care in many cancer patients, not only in breast cancer, and it has really changed, I would say, the way how we look at treatment and prognosis, even of metastatic patients. For the first time, we can say that even in metastatic patients, we can offer cure for some patients. So not for all, of course, but before, we must be honest, we couldn't cure anyone. But now we really have that chance, and immunotherapy has really shifted, I would say, our mindset of treatment. In lots of patients, because of this, breast cancer has become a chronic disease in some way. The patients live for several years, and I really think that that's a big success. But of course, we have a long road to go. Thank you again for organization of this event. I really enjoyed it, and I hope we will have some more in the future.
Thank you, Dr. Davor. Thank you again, Professor Yeşim Eralp, and thank you for all attending to this webinar. I hope we can meet again for different webinars. Thank you at all. Have a good day. Bye-bye.